What's up, AP Psych? Welcome back. We're hitting your final topic on this unit on mental disorders and therapies, and that is evaluating some of these different therapies, what makes them work, what therapies work for certain disorders, how effective are these therapies really? Those are some questions we'll answer as we hop into this. And a couple things to draw your attention to. Just in general, some of the things that make therapies work. There's client differences and events outside of therapy, which we'll talk about something called regression to the mean or regression to normalcy in association with that. And we have the therapeutic relationship. So the number one thing other than outside life events that has an impact on the success of therapy is the therapeutic relationship between the client and the therapist. So that's huge. And the therapeutic technique is not as important as some of those other big things. And the expectancy that you have of the therapy working or the placebo effect is also a chunk involved in what makes therapy work. So these are some of the biggest pieces and parts that make therapy effective or not effective based on the different things. So evaluating these therapies, who do people turn to when they're looking for help or they're having psychological difficulties? Most of the time, it's a physician. So this could be a psychiatrist, an MD, a medical doctor. Then you have mental health specialists, clinical psychologists, counselors, things like that. And then you have other professionals who people may turn to, like their clergy, their church, their priest, something like that, to help them through these different situations. Within these psychotherapies, cognitive therapy is the most widely employed, followed by psychoanalytic, psychodynamic. Then you have the family and group therapies, humanistic, and behavioral. So that's the breakdown, which can be surprising sometimes to see that cognitive is overall the largest, followed by psychoanalytic, which we know this one goes all the way back to Freud and his connections to the unconscious mind and things that happen in childhood. So after the basic breakdown, we have some perceptions of clients and therapists. If you ask clients about their experience of getting into therapy, they always overestimate its effectiveness. And that's just that placebo impact part. They always claim that it works and that's great for them, right? Which is good, it's beneficial. Critics, however, remain a little bit skeptical, thinking that and stating that clients, if they're entering therapy, oftentimes it's because they're in some type of crisis, and that crisis may subside over the natural course of time. And this brings us to the client differences and events outside of therapy. So what these critics are saying is it's maybe not the therapy that's actually helping, but it's just their life returning to a sense of normalcy, or what we call regressing to the mean or the average life. Then you have clients may need to believe the therapy was worth the effort, and clients generally speak kindly of their therapists. So we shouldn't necessarily take their own beliefs into account because they may be biased. Okay? The biggest thing to take away from here, though, is a vocab term, regression to the mean. And we have to be sure that it is the technique, the therapy technique that's actually helping these clients, and they're not just coming down from a crisis episode and returning to their normalcy. From a clinician's perception, like clients, they believe in the therapy's success. They believe that the client is better off after having received therapy than not. Okay. Now, clinicians are aware of failures, but they're mostly aware of the failures of other therapists, and they can overlook themselves. If a client seeks another clinician, the former therapist is more likely to argue that the client has developed another psychological problem, and clinicians are likely to testify to the efficacy of their therapy, regardless of the outcome of treatment. Okay, so there are many different clients, many different clinicians and therapists out there, so that makes this hard to measure the impact that we're seeing of these therapies. And these therapies can be hard to measure because we're talking about working with people's mental health, which is oftentimes hard to scientifically measure as well. So to try to push forward this idea that therapy is effective, there's been a lot of research in this area to help prove it. But Hans Eysenck suggested that 2/3 of clients improve whether they receive therapy or not, right? Because they're going to regress to the mean or regress to normalcy. But there was a problem with his studies. He only was able to review 24 studies, right? Because this was way before mental health therapies had become part of the mainstream. So there were very few forms of psychotherapy available. Today, there are hundreds of studies demonstrating the efficacy of psychotherapy. In 1980, Mary Lee Smith analyzed 475 different studies and showed that the average therapy client ends up better off than 80% of untreated individuals on waiting lists. Okay, so you're going to end up better than 80% of those who don't receive these therapies, even when accounting for those people who are regressing back to their average, their normal, their mean, right? So in general, those not undergoing therapy improve, but those undergoing therapy are more likely to improve. So it's going to help in the long run, and it may speed up that improvement as well. So what Mary Lee Smith did there was something called a meta-analysis. Okay? And this is when a psychologist or researcher wants to know the answer to a question that's been studied a great deal, like the effectiveness of seeking psychotherapy or not. They conduct this meta-analysis. They pool data from multiple studies. In Mary Lee Smith's case, over 400 studies to arrive at one combined and agreed upon answer. You analyze data from hundreds of studies, and based on that analysis, you come up with an agreed upon response or answer to the question. So the answer to this question was research and the meta-analysis showed that treated patients were 80% better than untreated ones. Okay, so you can see here some of the outcomes here. The average untreated person was in the poor outcome section, and the average psychotherapy client is shifted over to the right into that good outcome section. So more of them are receiving a good outcome than a negative or poor outcome. So that goes to show us that there is a relative effectiveness of psychotherapy. So which psychotherapy will be most effective for treating a particular problem? Well, we went over this a little bit when we discussed the different types of therapies and what they can help with, and I'll just give you a few here. This is obviously not an exhaustive list of all the disorders we talked about, just some of the common ones and the therapies that go along with them. So depression, you can treat depression with behavior therapy, cognition, interpersonal, humanism, biomedical, all of these different things, right? Anxiety, cognition, change the way you're thinking about that anxiety, exposure therapy, to help you overcome the anxiety of a situation, stress inoculation to get you thinking differently about stress and how it impacts your life. All those different things, different therapies work. You could also put in, biomedical therapy down here as well, medicine, medication. Phobias, you have behavior therapy with systematic desensitization as well as exposure therapy, all of these things. So realistically, many of these therapies could be used for a lot of different disorders. Okay? The success of any one therapy often depends on the individual client and their responses, right? So it's a case-by-case basis what's going to work best. So which type of therapy is best? Well, think about what I just said. No one type of therapy has been found to be superior, and there also appears to be little, if any, connection between a clinician's experience and their client's outcomes. So many people always want to look for an experienced therapist, someone who they think really knows what they're doing. They've been doing it for a long time, but there hasn't been any connection to see different outcomes for therapists with more or less experience. Therapy is most effective when the problem is clear-cut specific, like a specific phobia, like a specific stressful event, like a specific cause of major depression, things like that. And psychotherapists are striving to tailor specific treatments to specific problems, right? Talking about the individual client and their response, that oftentimes impacts the effectiveness of a treatment. And oftentimes when we looked back at that previous slide, the eclectic approach, using multiple types of therapy for any one disorder, is the most helpful, because then you can attack it from more angles and make sure that you're getting at it in the way that you need to. So a few therapists in their training, we've talked about these at the very back at the beginning of the year. You have clinical psychologists, mostly PhDs. They're experts in research, assessment, and therapy, and they're supplemented by a supervised internship. But because they're PhDs and not MDs, they cannot prescribe medicine. And then you have clinical or psychiatric social workers, masters of social work, plus postgraduate supervision. Prepares some social workers to offer psychotherapy, mostly to people with everyday personal and family problems. Then you have counselors. These could be pastoral counselors, abuse counselors, school counselors. They work with problems arising from family relations and substance abuse or school issues with your spouse, child, things like that. And finally, you have psychiatrists, and these are the medical doctors. They go through med school and residency, and they specialize in the treatment of psychological disorders. Not all psychiatrists have extensive training in psychotherapy, but as MDs, they can prescribe medication. That's oftentimes the route that they take. So just a couple more things to consider when evaluating the effectiveness of psychotherapies. Cultural differences, including religion, and if you come from a collectivist or an individualist culture, can create a miscommunication or mistrust that threatens the client-therapist relationship. And we know that the client-therapist relationship is one of the most important factors that determines the success of a therapy. And if you have issues and trust issues and miscommunication in that client-therapist relationship, oftentimes it can result in early termination of therapy. So depending on the culture that people are coming from and the expectations that they have, they can seek therapy more readily or be more ready to end that therapy when something happens that they no longer feel they can trust their therapist. And so within those situations, there are some rules and rights designed to protect clients so that they can develop that trust and not end therapy too early. So there are ethical standards in place to ensure the relationship does not harm the client. One, there's no intimate relationships allowed between client and therapists during therapy or for at least 2 years later. And confidentiality is a big one. We talked about this with our ethical standards with research methods. So much so that information revealed in therapy is privileged communication, client-therapist privilege. And clients also have rights when it comes to being committed to a mental hospital by their therapist. You cannot be just casually committed to a mental hospital. You have to be proven or shown that you are creating an immediate danger to yourself or others. And oftentimes a judge has to sign an affidavit saying that you are an immediate threat to yourself or others before you can be committed to a mental institution against your will. Okay? You can obviously voluntarily enter one if you'd like. So those are there to protect clients and to hopefully help them build that client therapist relationship so that they can get through those issues that they need to. Okay? So all of this is to just remind us that psychological disorders in today's world, as we learn more about them, we view them as psychosocial issues, trying to identify those biological markers and techniques, including drug therapy that could help, while also gaining insight to the ways people are thinking and how they can change those thoughts. And at the same time, understanding the social environment and the culture that they're coming from in order to be effective and treat them in a respectful way that's going to gain the most success. Okay. So that wraps up our evaluating psychotherapies. We'll see you in class for the end of the unit, and let me know if you have any questions.